You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 28th, 2023. This week, antiarrhythmic drugs in patients with coronary disease, observational studies and evidence translation, GLP-1 agonist, and the subcutaneous ICD. First topic is antiarrhythmic drugs in patients with coronary disease. Before I tell you about the study in question, let me recount a meeting I had years ago with a group of brand new advanced practice clinicians. I was sent in to teach on the use of evidence. So just for grins, I proposed this at the meeting. I said to the group that if you had access to the chart of every patient in this hospital who took a drug like Flecainide, and say every patient who took Sotalol, and the electronic health record was perfect, you had perfect data, then could you tell anything about the outcomes in these patients on these two therapies? Nearly every young person nodded yes. But of course, this isn't true, because there are baseline differences. Clinicians make these decisions. That's why you need randomization, and I explained that, and I think they got it. I think. Now, a study published in the journal JACC-EP from the EP group at Emory has stirred so many emotions in my brain. This was a retrospective chart review study. Their question centers on the use of type 1C antiarrhythmic drugs, which are Flecainide and propafenone, in patients when there is coronary artery disease. And I know just saying that sentence sounds scary. No, it sounds scary because the therapeutic fashion for the past 2 decades has been to never use these drugs in not only patients who have coronary disease, but also in patients who have any structural heart disease, however that is defined. Now, this topic, this antiarrhythmic drugs in coronary disease literally overflows with concepts from evidence-based medicine. Even if you've never used these drugs, you're not an EP, or not even in cardiology, this is an incredible topic to discuss critical appraisal and evidence translation. Now, first thing you have here is the critical appraisal of the CAST trial, a study that I cite as one of the most important studies of a generation in any medical field. Then you have the critical appraisal of this specific study from Emory, which I'll get to. And finally, you have the issue of applying trial data to patients. Now, before I start, let me say what trials are for. Trials give us average effect size in the population that's studied, in the environment that it's studied in the trial, and at the time the study was done. The patient that we're going to treat is probably different from those in the trials. Their situation may be different than that in the trial. And that is where David Sackett's 3 circles of evidence-based medicine comes in. Remember, evidence-based medicine is the mixture of A, clinical judgment, B, best evidence, and C, patient preferences. So with that intro, let's start with a CAST trial. That's where all this came from. You probably know that CAST randomized post-MI patients who had PVCs to a 1C drug or placebo. You probably also know that the trial found a large increase in the risk of death or cardiac arrest. The number needed to kill in CAST was 29. And CAST upended the ensconced practice of suppressing PVCs after MI. But more importantly, it glaringly showed the value of randomized controlled trials and the danger of making causal inference from the many observational studies that had shown PVCs associate with higher mortality risk. However, CAST was so scary that it led to a decades-long prohibition on the use of 1C drugs in patients with any coronary disease or even any structural heart disease. Guideline documents reiterate this proscription. Now, here's a typical case that stemmed from this practice. A 65-year-old man has had AFib that has been 100% suppressed with Flecainide for years. He tells his family doctor he has fatigue, and his family doctor gets a nuclear stress test, which comes back positive, of course. At cath, he has a circumflex disease and gets a stent to his mid-circumflex. The artery is now perfectly well open, the LV ejection fraction is normal, the QRS is normal, and he's passed a post-stent stress test at some point, but because he technically has coronary disease, and that is considered structural heart disease, his cardiologist stops the Flecainide. Even though this patient is nothing like a post-MI patient with an EF of 25% in the 1990s when CAST was done. This patient has his atrial fibrillation comes roaring back, and sotalol, a class 3 drug, is ineffective. He now gets an AF ablation. After the AF ablation, he gets a flutter, left atrial flutter, has to have another ablation. So you see the problem. He's now had to undergo 2 expensive and potentially risky procedures for a problem that was beautifully controlled with a well-tolerated medicine. So CAST is an important trial, but experts have massively overextended its findings. Consider the following facts about CAST trial. It enrolled patients in the late 1980s. This was well before the current stent technology. Background medical therapy now is many-fold better. And only 1 in 3 patients in CAST were on a beta blocker. Subsequent post-hoc studies had found that beta blockers use in CAST had reduced the increased risk of antiarrhythmic drugs, and finally, the average EF in patients in CAST was about 30%. Those facts make it extremely difficult applying CAST to patients treated with beta blockers and statins who have normal EFs and no ongoing or inducible ischemia in our current era. In 2010, now 13 years ago, Drs. Dan Kramer and the late Mark Josephson wrote an editorial entitled 3 Questions for Evidence-Based Cardiac Electrophysiologists. It's a great piece. I will link to it. Their first question, one of these 3 first questions, was just what I mentioned about applying CAST to current patients with different kinds of coronary disease, and I think the opinions expressed in that piece from 13 years ago hold up well. Okay, now that was a long introduction. Now let's move to the Emory study. Emory is a big place, so they have lots of patients. They did a retrospective chart review from 2005 to 2021. About 3,400 patients took a 1C drug. They then created a control arm of about 2,200 patients who took sotalol or dofetilide. Those are type 3 antiarrhythmics. Obviously, this is not even close to a randomized comparison. It's not prospective either. It's just a look back in charts. They excluded patients who were treated for VT or had ICDs or had non-revascularized MIs. They created 3 groups for CAD, that is no coronary disease, non-obstructive, or obstructive. They then, of course, ascertained clinical outcomes, including the primary endpoint of death, VTVF, or admission for heart failure. They did regression correlation analysis looking at the effect of 1C use on event-free survival across varying degrees of coronary disease. Now, obviously, there are going to be huge differences in baseline characteristics, but they adjusted for baseline variables, and they found, get this, sit down for this, 4.6% of patients on 1C drugs had a primary endpoint versus 9.4% on a class 3 drug. That's a 5% absolute risk decrease. It had a p-value of very low, 0.001. The rate of all-cause mortality was similar between the class 1C and class 3 groups, so 1C drugs did not increase death rate. And after they adjusted for the covariates, class 1C use was independently associated with a better event-free survival compared to class 3 use, and the hazard ratio was 0.40, so the association was a 60% reduction in events. This is not a misstatement. In this study, class 1C drugs looked massively protective. Now, looking at subtypes of coronary disease, they found that in patients who had obstructive coronary disease, taking 1Cs looked worse. The hazard ratio here was almost 4.0 for the primary endpoint. But in patients who had either no coronary disease, there was no significant increase in hazard. My friend and former IU doc, Dr. Gerald Neccarelli, wrote the editorial, and he cited a number of very similar contemporary observational studies, just like this one, which also have found no increase in hazard with type 1C use in patients with coronary disease. So my comments, here we have a conundrum, don't we? We clearly have overextension of the 1980s and 90s vintage CAS trial done in patients who had sick ventricles, most of whom had scar. A person who applies evidence could not apply that data to contemporary patients with mild coronary disease or revascularized coronary disease who have normal ventricles. But that is our situation currently. This is a shining example of the weakness of expert opinion and the sclerosis of therapeutic fashion. But studies like this one from Emory are not the way to upend wrong-headed expert opinion. I like this group at Emory, but this study is potentially dangerous. I mean, they found a 60% reduction in serious outcomes in patients taking 1C drugs. The chance that this represents residual confounding, i.e. healthier patients got the 1C drug compared with sotalol and tofetilide, is about 99.99%. And if that is the case, why do such a study? I read the methods and it looked to me like a very basic attempts at matching. I did not see any attempts at propensity matching, nothing about falsification endpoints, nothing on E-values or the use of instrument variables. The answer to appending dumb expert opinions on 1C antiarrhythmic drug prohibition in patients with minimal heart disease or mild coronary disease is not to do flawed retrospective chart reviews. Of course, an RCT would answer the question, but it's unlikely that an RCT is going to get done. Short of that, I wonder if we simply need new experts. Experts that think better, experts that take care of patients more regularly, and perhaps experts that don't do med-mal work. It seems to me that if you do med-mal work, you should not be allowed on a guideline document or expert consensus statement. All right, next topic is GLP-1 agonist. Last summer, the New England Journal of Medicine published the results of the SURMOUNT-1 RCT of once-weekly Tirzepatide for the treatment of obesity, and at 1.5 years, the glucagon-like peptide-1 receptor agonist, GLP-1 agonist, induced substantial weight loss versus placebo. Go look at the main figure in that paper. Patients in the 10 to 15 milligram dosing arm had more than a 20% sustained loss in weight over the 1.5 years. Think about it, 20%. In less than 2 years, a 250-pound person is now 200 pounds. That is remarkable. Last month, The Lancet published the SURMOUNT-2 results. Again, at 1.5 years, patients with type 2 diabetes and obesity sustained substantial weight loss. The delta here was only about 10%, which was less than in SURMOUNT-1. And the author suggests weight loss in type 2 diabetes is more challenging. Well, now, the makers of the drug, Lilly, have announced top-line results of the SURMOUNT-3 and 4 studies. To get their flavor of the results, let me read the lead of the journalist Mitchell Zoller's story. Quote, "The Tirzepatide weight loss juggernaut barreled forward with a report on July 27th of positive top-line results from a pair of pivotal trials in adults with obesity or overweight but without diabetes." Now, this was a statement from the press release. Participants in the SURMOUNT-3 trial, after 12 weeks of intensive lifestyle interventions, achieved an additional 21% mean weight loss with Tirzepatide for a total mean weight loss of 26% from study entry over 84 weeks. Participants in the SURMOUNT-4 study achieved a 21% weight loss during a 36-week Tirzepatide lead-in period and an additional 6.7% weight loss during a 52-week continued treatment period for a total mean weight loss of 26% over the 88 weeks. Now, both of these studies will be presented at future meetings. Tirzepatide is available on the market here in the U.S. as it received FDA approval in May of 2022 for the indication of improving glycemic control in patients who have type 2 diabetes. These studies each have an interesting twist. The twist in SURMOUNT-3, where adults with obesity had to lose 5% of their body weight in the run-in period with lifestyle interventions, then they could enter the placebo-controlled randomized trial. SURMOUNT-4 also was pretty nifty. This first part was Tirzepatide versus placebo, and of course this led to a 21% body weight loss. Then patients were randomized to continue Tirzepatide versus placebo, which is kind of interesting. And at the end of the one-year randomized phase, those who continued Tirzepatide had an average additional weight loss of 6.7%, while those who switched to placebo had an average 15% weight gain during that phase. Now, in a related story, Mitchell-Zoller also covered reports that semaglutide use has surged in U.S. adults who have type 2 diabetes. In an abstract presented at the European Association for the Study of Diabetes, this showed that semaglutide was now the top incretin-based drug class. The main finding was that by March of 2022, so the first quarter last year, 57% of U.S. adults with type 2 diabetes who were prescribed an incretin-based treatment were taking a GLP-1 agonist, and 39% were taking a DPP-4 inhibitor. And these usage rates sharply diverged from 4 years earlier in that same period when it was actually 2/3 DPP-4 versus 1/3 GLP-1. We also learned from Mitchell-Zoller's story that semaglutide has the early lead over Tirzepatide. Zoller also tells us about the Tirzepatide SURPASS cardiovascular outcomes trial, which has enrolled more than 13,000 patients with type 2 diabetes and will measure cardiovascular outcomes, MACE, and results are due next year. My friend, SURPASS CV outcomes trial is going to be super important. If Tirzepatide results in both a very large weight loss and clinically significant MACE reductions, well, that would be something. Plus, if you can show 20% weight loss leads to fewer major adverse cardiac events, then that certainly lends credence to obesity as a serious disease in and of itself. So some comments. First is that I don't like pre-presentation announcements. I know this may be couched in regulatory rules, so for instance, like for investors, but it's a convenient marketing technique because it presets the conversation, doesn't it? Kahneman and Tversky call this anchoring. I understand it as you start the interpretations of studies in a positive light. The second thing I'd say is, look at what FDA can get companies to do. I don't understand why this isn't the norm with devices. When Tirzepatide gains approval, we will have many thousands of people randomized. Third thing I'd say is that these drugs present us with a real thinking exercise, don't they? For if you see obesity as a medical disease and weight loss as the ultimate goal, these drugs get the job done, no question. In the short run, they are also surely lower risk than obesity surgery. But the caveat here is that in the absence of outcomes trials, more outcomes trials, weight loss remains a surrogate outcome. But on the other side of the coin, if you see obesity as more of a societal norms issue, to wit, the differences in physical appearance in European versus American airports is striking, then the notion of taking long-term use of injections makes you wonder whether our norms shouldn't be adjusted. And perhaps these norms should change in schools. And childhood obesity just saddens me. What's more, while we have RCTs with these drugs for months to a couple years, there will surely be the issue of unknown unknowns with long-term use. Because it looks like stopping these drugs brings weight gain. So we are talking about long-term use, I think. All right, final topic is the subcutaneous ICD. Age has a way of changing your view on things. Implantable devices is one of those things. When I was young, during the era of irrational exuberance for ICDs, after Made It 2 and SCUDHEFT, when key opinion leaders were saying we didn't have enough EP doctors to implant all those needed ICDs, I was at least somewhat swept up in the excitement. Now, I knew then that there could be long-term downsides, but the present took precedence over the future. Now that I'm older and practiced long enough to see patients who have had problems, say, for instance, those dual-coil ICD leads that have gone bad or been abandoned, and then got infected at a time of a generator change, I've grown more concerned about long-term complications from the transvenous leads, and so the S-ICD offers a tantalizingly plausible solution. You can still get the backup defibrillation, but everything is subcutaneous, the lead and the ICD. But the S-ICD does come with serious downsides. Not having a lead inside the heart results in poor sensing, which leads to higher rates of double counting and inappropriate shocks. It also results in no ability to pace. And, of course, the ability to effectively defibrillate the heart can become an issue if the leads are not inside the heart. This week, in JACC, a large group of authors published a study called the S-ICD System Post-Approval Study. 86 centers in the U.S. enrolled patients in this FDA-mandated single-arm study, which was intended to be a real-world registry. The primary efficacy endpoint was overall shock efficacy in converting VT or VF through the 5 years. The primary safety endpoint was complications from the S-ICD system itself. More than 1,600 patients were enrolled and median follow-up was 4.2 years. The abstract says that the study met its primary efficacy and safety goals. Shock efficacy was 98.4%, and it remained stable over the years. The S-ICD-related complications were 6.6%, electrode-related complications was less than 1%, and only 1.6% of patients had their device replaced by a transvenous system, and the authors concluded, quote, "These results demonstrate the 5-year S-ICD safety and efficacy for a large, diverse cohort of S-ICD recipients." But we should dig a little deeper, since this study earned a supportive editorial and will likely be used in marketing material from the company. The inappropriate shock rate was 6.7% at 1 year and 15.8% at 5 years. That is very high. And it was due mostly to cardiac oversensing. I just went back and looked at some comparison in Danish, which was a 2016 ICD-RCT. The inappropriate shock rate was 5.9%, but most of these were due to atrial fib rather than sensing problems. S-ICDs are often implanted in younger patients. In Danish, the inappropriate shock rate due to oversensing was less than 1%. Now, the other problem with this study is that it was voluntary. I could find no discussion about mandatory enrollment. I mean, you could be an implanting center and decide who gets in the study. This is a massive difference in my mind from the mandatory STS registry for, say, TAVR. Or if you are an S-ICD proponent, you might not enroll patients you had the most difficulty with. Voluntary registry studies are very problematic due to the systemic bias. Now, the other problem with this study is a huge number of dropouts. The beginning number was 1,643 patients and 665 patients finished. I subtracted from the original number the 288 patients who died and calculated that 50% of the cohort exited the study. 50%, that's not a misstatement. The most common reasons for exiting the study before the 5-year follow-up were an inability to be followed at the study center and loss to follow-up. Here are some comments that I'll make. Now, I've implanted a handful of S-ICDs. They have plausible reasons for use, especially in young people who you believe benefit from VF backup. But the evidentiary support for this device is extremely weak. We can make no reliable conclusions from this study regarding overall efficacy. How can you if more than 50% drop out of a voluntary study? Also, consider that we know this is done in expert centers, and these are likely S-ICD proponents, and still, there was a 1 in 6 chance of receiving a high voltage shock while wide awake inappropriately. Another problem with the evidentiary support for the S-ICD is that there were adjudication issues in the Praetorian trial of the transvenous ICD versus S-ICD. This study, published in the New England Journal of Medicine in 2020, was a non-inferiority trial comparing the S-ICD as the new treatment and transvenous ICD as the standard. And it reported and is widely cited as meeting non-inferiority in its primary composite endpoint of device-related complications and inappropriate shocks. But Rita Redberg, Bogdan Inaki, and I have documented in a published letter to the editor in New England that the Praetorian trial would have missed non-inferiority if the investigators had used their original definition of appropriate shock as a shock for VT greater than 180 beats per minute. Now, that is a definition which they had used in a previous study. I will link to the letter to the editor, but the summary is this. Of the 83 patients in the S-ICD group who had shocks labeled as appropriate, 11 had shocks for VT below the cutoff of 180 solely because of oversensing of cardiac signals. For example, a VT at 150 beats per minute could have been sensed as 300 beats per minute and got a shock. And we estimated in our letter that if approximately half of these oversensed ventricular tachycardias had been labeled as inappropriate, non-inferiority would not have been met. Now you see what I mean here? When the GLP drugs come to market, we will have many-fold more data than the S-ICD device. I don't understand why the FDA has such lenient standards for implantable devices relative to drugs. I mean, the makers of these devices have plenty of money to fund appropriate trials. Post-market studies are certainly better than no post-market studies, but treatment of something as serious as ventricular fibrillation should come with a mandatory registry wherein every patient is enrolled. Now, even better would have been a policy such as reimbursement with evidence, right? The post-market study had about 1,600 patients. Imagine if these were randomized to a transvenous ICD for S-ICD, we would have doubled the number in Praetorian. I just think we need better data with devices, and we need to force these companies to fund these trials. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider giving us a rating. Even those 1 or 2 sentence reviews go a long way to helping others find us. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.